and I'm the support facilitator at the Self-Management program of Southeastern Ontario. We would like to welcome you to the fourth of our series of Lunch and Learn webinars for healthcare professionals as part of our efforts to build various communities of practice in the region. I just have a few housekeeping pieces to mention before we begin. As you will notice, you are all currently muted. In just a moment, I'm going to unmute everyone. So if someone is on the phone, but for some reason you can't access the webinar, please, at that point, speak up and let us know, and then I can take down your information and we can troubleshoot offline as things continue. Then before beginning again, I'm going to mute everyone once more, just so we don't have all that background noise. If you have any issues during the webinar, however, you can get my attention by virtually raising your hand. So on the little dashboard that you're seeing, there should be a little image of a hand that you could click on, and that will let me know that you need to get my attention. Or you could also put some questions or just let me know that you need some help in the chat discussion board as well. And when you type in there, I will see that. So at the moment, I am going to unmute everybody, and then just speak up if you're having any technical issues or need to let me know anything. Okay, so everyone should be unmuted. If you've got anything that you need to let me know, or if you're on the phone but not on the webinar, now would be the time to say it. If you're also running into issues and for some reason can't voice it, you can also email me at the selfmanagement@kchc.ca email. That would have been in all of your reminders. So does anybody need to speak up at this time? Okay, so in that case, I'm going to mute everybody again, and you can email me with any issues or contact me in the chat or with the hand tool. So just a couple other pieces. Let's see. So we will be taking questions throughout the presentation, so feel free to type them in that chat box I was talking about as you think of them. And then what I will do is I'll let our presenter know in between slides that there are questions waiting, and I will voice them. And at that time, too, I will unmute the person asking them so that there can be a discussion if necessary as well. And at the end, we'll also have another question and answer period, too, in case you didn't think of anything throughout. So just to remind you as well, there are printouts of the slides with spaces for notes that can be used, as well as a handout. They're available on our website for download, and the direct link to do so was also provided in the reminder emails that you should have received. Now I would like to present our speaker for our fourth webinar, Cognitive Behavioral Therapy, Diabetes Management with CBT Techniques. Michelle Sorensen is a member of the Ontario College of Psychologists and has a private practice in clinical psychology in Ottawa. Using a cognitive behavioral approach to therapy, Michelle helps patients with a wide range of issues. Working with patients with diabetes is an area of particular interest for Michelle. She combines her knowledge about changing thoughts, feelings, and behaviors with the understanding that comes from personally living with type 1 diabetes herself for over 14 years. And it helps the patients feel better while managing their diabetes. So now I am just going to pass on the screen and the audio to Michelle, and we'll be able to go from there. So just a moment. Now, Michelle, once you click the button, you should have the screen.
Okay, here we go. Okay, everyone can see the slides okay?
Yes.
Okay, perfect. Just fixing. Okay, great. Hi, everyone. Thanks so much for joining us today. I'm looking forward to this opportunity to talk to you a little bit about CBT, which is a real passion of mine. It's the kind of general framework that I use in my counseling with patients of all types, and I certainly have found over the years as I've become to develop, more and more of a sort of niche in my practice working with people with diabetes, both type 1 and type 2, that using CBT techniques, it's really helpful because with diabetes we have such a close connection between emotions and thoughts and behaviors. And so what I'm hoping to convey and to help everyone understand today is how that can apply to our practice. What I always say when I'm, talking with nurses and dietitians and other healthcare practitioners is that much of what I will talk about from a sort of, my psychology training perspective I'll touch on things that many of you already do in your practice, naturally, sometimes without having a name for it. Some of you may have some training in CBT, and so you know that you're using those techniques. But you'll recognize much of this as just good counseling and communication techniques. But when we're more aware of what we're doing right, then we can do more of it. So just to move on to the first slide here. Oh, sorry, hold on 1 minute. There's something I need to... Oh, I'm just having trouble moving my slides. Sorry. Danielle, I'm just having, oh, there we go. Never mind, I'm sorry. Okay, so the cognitive behavioral model. So basically, we can change the way we feel by changing the way we think. This is the core teaching of cognitive behavioral therapy. When we balance our thoughts, we regulate our mood, which enables us to engage in more positive behaviors. So we need to gain a better understanding of our negative self-talk, all those negative thoughts that run through our mind. And as I say this, you may think of some of the ones that run through your mind. All of us have them, negative automatic thoughts. But we have to identify them and be able to, often say them out loud or, work on them before we can change them. Now, the layers of our cognitions include sort of surface thoughts, those negative automatic thoughts. So an example would be, someone who's struggling with their diabetes would have thoughts like, oh, I'm always messing up, I can never get this right. Then underneath those surface thoughts are underlying assumptions. And those I often refer to as the kind of unwritten rules that we live by. They're if-then sort of statements, like if my A1C is not in range, then I'm messing up my diabetes. Or if I don't manage my diabetes, then people will be disappointed in me. So there's those kinds of thoughts too. And then at the deepest layer, we have core beliefs, which I don't always get to in therapy with people. We don't always get to this level, and certainly it's not always going to happen when you're working with patients. But sometimes good to be aware that there's these core beliefs that are operating, which are sort of statements about yourself or about other people or about the world around you, things like, I'm a failure or I'm not good enough. So what I'd like to do at this point is just talk a little bit about a recent patient I saw to kind of give a bit of context for what we're talking about here. And then this patient, who I'll call Amy, excuse me, as we kind of move through the slides, maybe we can think about Amy a little bit, and it'll just kind of help us to make sense of what we're learning. So Amy is a young adult in her early 20s, and she was referred from her endocrinologist at the beginning of the summer. She was home from university, starting grad school this fall here in Ottawa, back home with her family. And so her endocrinologist referred her because she'd been type 1 since early childhood, since a young age. And she's tended to have problems with her management, as do many kids with type 1, of course. And lately her A1C had been higher than usual, sort of hovering around 10, and she wanted to work on this, and certainly her endocrinologist wanted her to, and sensed that there were psychological issues that were getting in the way in terms of testing. So the referral note from the endocrinologist said that testing was problematic. She was having trouble with management. So when Amy came in to see me, she, in the first session I always do an assessment, and so we kind of used that hour to try and look a little bit at her overall history and then identify some goals and really just get to know each other. So Amy was able at the end of the session to share some goals. She could identify that she'd really like to lose weight. She's always struggled with weight and body image. She'd like to have a romantic relationship. She's never had a boyfriend. And she'd really like to reduce her A1C, obviously. So when she came back in the second session, she'd already started to make change. And maybe some of you see this too sometimes, that just when people are ready to come and see someone for help, they're ready to make some change. And sometimes, if we're lucky, they get activated on their own. So she was testing a little more often. She had really not been testing very much at all at times before. Was seeing an improvement in her blood sugars, and obviously she's just safer at this point because she is on the pump, so she's on continuous insulin, and the testing is so important. So in the second session, if we're looking at how our thoughts affect our mood, which affect our behavior, she was able to voice some thoughts about, not feeling very good about the fact that she didn't exercise. And what I tried to work on with her was, instead of, just setting concrete goals, but thinking about, like, why is that difficult? What are her thoughts about exercise? What are the things that get in her way? And she identified that she really doesn't find it a lot of fun. So I didn't give any direct advice. Instead, I sort of looked to her as the expert and tried to get her to think of things. And I threw a few thoughts out there, like that I'd heard other people talk about apps for their phone, using a fun app that, I don't know, led you through ab workouts or something like that, and hoping it would sort of give her some ideas. So she went away. She came back for her third session, and she was on week 4. We'd had a bit of a gap because she'd been away on holidays. So since I last saw her, she'd been running, which was a big change, big behavior change, but it came from changes in her thoughts. So what she described was that she was thinking about exercise as being a lot more fun because she'd researched apps, and she found an app. Like, I learned something from my patients every day, and I really learned a lot from Amy because I didn't even know apps like this existed. But she found an app that combined a few of her favorite things. So she loves zombie movies, and she loves video games. And I said to her, I don't understand why you don't have a boyfriend, because these are things that most young men just love, and she sounds like a model girlfriend, a perfect girlfriend. But she had discovered this app that was, you listen to it on your iPod or your iPhone, and as she runs, zombies are running after her, and then she has walking intervals, and it's sort of like you're in a video game. So she said it just made her look forward to going out running. So that was one piece of progress that I thought was great, and it was just wonderful to see her thinking in a more positive way. But then she also talked about what she was still finding problematic. And one of the big obstacles for Amy in checking her blood sugar is that her part-time job, she said, it was very hard at her part-time job to manage her sugars to test. So her part-time job is working in a nursing home, and she said that during the busy period, which is like 2 or 3 hours, when they're serving meals to the residents and, helping with getting all the food out and putting it away, that it's just too busy to check her sugar. Now, I think that when we're working with patients, there's moments like this where, I had lots of ideas and advice that came to mind, like maybe you could check your sugar right before you start the busy period, or can't you talk to your boss and all you really need is 30 seconds to check your blood sugar, right? But I know that human nature is that when we give direct advice, people tend to come up with all the reasons why it won't work. So instead, I just was curious, and I asked Amy to tell me a little bit more about, what her work was like and, why it was hard to check. And so what she ended up sharing, as she sort of put her thoughts into words and said them out loud, she was very concerned about being productive and being a good employee. Some of her colleagues she did not see as very hardworking. She would never want to be like that. And so she said, I always put the residents first. And so we talked about that. And as she said it out loud, she said, but, I know I can do that and maybe still manage my sugars. And then when we explored it a little bit further, she said that, well, when she does, I said, have you ever checked your sugar, at work? And, well, yes, and when I do, people ask me about it, and then I have to talk about the fact I have diabetes. And then she's worried, so the underlying assumptions are that people will think that she's diabetic because she's overweight, and that they will judge her for that. And so we ended up getting into some of these, bigger underlying issues, and it was amazing because as she said them out loud, she was the one who started problem solving and coming up with ways in which she could, yes, check her sugar before it gets busy at work, and that she can assert herself, and if she doesn't want to talk about the diabetes a lot, she can just, thank people for their concern and move on. So I'm just sort of giving that case as an example to look at how, helping people to identify and say out loud their thoughts really helps us to regulate mood and then move to behavior change. Because the thoughts that are trapped in our head really gain a lot of power. But when we put them into words, when we say them out loud or we write them down on paper, sometimes we can hear ourselves, some of, sort of the weaknesses in our thinking and the things that we can balance a little bit. So just before I move on to the other slide, any questions about that example or any thoughts on that from anyone? Danielle, are there any questions coming up at all?
I haven't seen any at this point. Not so far.
Okay. Well, anyone who has any, you can always make a note if there's any questions about that, and we can always come back to it. Okay, so now we just have a slide that gives a little bit of a visual of what I'm talking about. So we're looking at the mind-mood connection here. And really there's 4 different components that we take into account. So everything happens within the context of our environment. So that's the big circle that we're kind of working within. And then it's our thoughts that lead to our emotions, our moods, and that impacts our behavior, which then affects our physical symptoms. So things like insomnia or appetite or aches and pains, and can lead back into more negative thoughts. So negative change in one area can lead to negative changes in other areas. And if we think back to the example with Amy and how she was feeling before she came in, I mean, she had lots of negative thoughts about the fact that she wasn't active and that her A1C had gone up. I always say that when you live with diabetes, you have multiple opportunities to think badly about yourself throughout the day, right? With what you're eating, with what the number on your glucometer says. There's just so many different things. So lots of negative thoughts for Amy, which was leading into her being kind of down and frustrated, which then leads into negative behaviors, such as withdrawing from activities that could be good for her because her self-esteem is down. Maybe shutting off communication with people like her parents, who she knows will be concerned, but she doesn't really want to hear what they have to say. And then physical symptoms like feeling fatigued, gaining more weight. So you can kind of see how a negative cycle gets going. But the good news here is that positive changes can work in the same way. So it's not all doom and gloom. If we look at this exact same model and we say, okay, if we start to balance thoughts, like when Amy starts to balance out her thoughts and thinks, okay, I can find a way to make exercise fun, and going for a run doesn't mean that I start off running a half hour. I can walk for 2 minutes and run for 1 minute. I can mix it up. I can just do my best. And it was amazing how she started to problem solve. Like, she told me that one day she had a sugar low right as she was about to walk out the door and checked her sugar. And rather than a time where she would have just said, where her thoughts would have been, well, this means I can't exercise. It's so hard to fit it in when you have diabetes. Instead, she problem solved, and she waited a half hour while she had a snack and some juice, and she was determined to still go out on her run. So we can see how when we balance our thoughts, we regulate our mood. It doesn't mean that we eradicate negative moods. It doesn't mean that we don't have any anxiety or that we never feel sad, but it means that we bring those moods down to a manageable level where we can still feel good enough to then engage in the next component, which is the behaviors that help us to get better. So usually when people are engaging in positive behaviors, when they're connected to others, when they do things that are good for themselves, it helps the physical symptoms like fatigue and insomnia and things like that. And then, of course, that leads into more positive thoughts like, I can make a change in my life. So as practitioners, when we're looking at this model, I think that really our job is to find the smallest changes that lead to the biggest improvement in the whole system. So every little bit better is better. So anything we can do to help them make a positive step, if it gets that cycle going and it inspires them to make more change, then they're doing the work on their own. They don't need us to help them with every change. So why is diabetes care so challenging? Well, definitely these negative thoughts, assumptions, and beliefs, they really interfere with diabetes management, just as negative thoughts and assumptions and beliefs that people have interfere with positive behaviors in their lives. It's not just with diabetes, that's for sure. And negative thoughts don't just go away. They need to be replaced. So when we really use a lot of the CBT techniques, and some of these things that I do in therapy are a little more complicated. Like one of them is in your handout, a thought record. Although once you get used to using it, it's not complicated, but the learning it and the putting it into practice can seem a bit intimidating at first. But the reason that we do some of those techniques is because we need to develop new, more balanced thoughts. And sometimes people can do that in conversation, and sometimes they actually need to look at things in black and white. So this makes it challenging in that we can't just make thoughts go away. We have to replace them with new, healthier thoughts. So for example, someone afraid of hypoglycemia might have recurring negative thoughts such as, I can't handle being low, I'll end up dying from a low blood sugar. So I'm not, because I'm not familiar with all of the kind of work that you do, I'm not sure how much each of you works with type 1 patients, but I know that a big issue I see with a lot of my type 1 patients, and the reason some of them end up coming to therapy, is that they're so afraid of hypoglycemia, and understandably, because it is a very real risk, the consequences, that they do have these kinds of thoughts, like I'll end up dying from a low blood sugar. But they're not just working to prevent lows, they actually end up feeling much safer with very elevated sugars. Although of course we know that has all its own risks. So these are very difficult thoughts to change sometimes, because the longer they end up living with these thoughts and avoiding being low, the more they believe that they can't handle it if they bring their sugars into range, that something terrible will happen. So often what we need to do with some of these really deeply entrenched negative thoughts and beliefs is we need to explore the evidence and challenge the thought. And if we have time today, I'm hoping to go through the thought record in our handout just to give a little bit more information about that. So we then try and develop more balanced, realistic thoughts. In this example, it might be something like, it's unpleasant going low, and it can be unsafe, but I can stay safe by checking my blood sugar regularly, juice in my purse. And of course, there's other thoughts we can work on. Some of my patients and I myself actually now use a continuous glucose monitor. So sometimes, that's something people can consider. And if we look at the case with the example with Amy that we just talked about, she was already on her own without doing any complicated thought records or anything like that. Just by speaking out loud, she was starting to develop a more realistic way of thinking about things like what other people would think about her checking her blood sugar. She was able to challenge some of the negative thoughts that were not necessarily based on evidence. So I'd like to go over what I call a diabetes counseling model. So I've kind of pulled together the things that I see myself doing most with my patients with diabetes and trying to put it into a bit of a model that hopefully some of you can refer back to, and you can take the bits and pieces that apply to you and see if they work in your practice. So I consider this model to be informed by CBT and also motivational interviewing. And we're not talking about motivational interviewing in detail today, but it definitely comes into my work. So this model addresses moods like anxiety, depression, anger, and other emotions that are related to diabetes distress, like frustration or loneliness. So diabetes education, according to this model, is seen as a really collaborative process. And that is actually a key component of CBT and of motivational interviewing, that we're looking at the patients as experts too. So it's very collaborative. The counseling support focuses on the patient's efforts and not just on the results of those efforts. So this is something that I talk openly about with my patients. I say, you can't just look at the outcome, you have to look at the effort, right? If someone has a week where they're really trying to manage their blood sugars, say someone with type 2 who's taken up some exercise, who has cut out a few of their treats or tried to find healthier substitutes, and their sugars aren't coming into range as much as they were hoping, but they're really making the effort, then we have, in order to give them the motivation to keep going, you have to get them focusing on what they do and not just on what the numbers say. So using this model, the hope is that interactions are more rewarding for us as counselors or educators, and also more empowering for patients.
Hi, Michelle. We actually have a question. Is this a good time?
Yeah, perfect.
Okay, and then you can let me know if you want to open it up for discussion or if you've got a straight answer. So we have a question from Debbie, and it says, my DM follow-ups are with a lot of elderly people who I have a hard time trying to get them engaged in physical activity as they have a lot of excuses. How can I help them to change? Yet they are motivated to come and see me every 3 months, and I ask them if they see their diabetes as a health concern. Some say no, it's just a pain in the ...
Okay.
So I'll unmute Debbie at this time, and you just let me know if we need to go wider than that.
Yeah, if anyone else wants to comment. Hi, Debbie. So I think that that's an excellent question, and it's something that we could apply to so many different demographics and different types of issues. What do you do when a patient appears unmotivated, but as you're pointing out, there is some intrinsic motivation because they're coming to appointments. Maybe it's because Debbie's really wonderful to talk to, like that could be some of it, but absolutely they are, and this is the truth with most patients, is that even if they appear really unmotivated, there is some motivation. We just have to figure out how to tap into it. So one of the things we'll be looking at with the counseling model is that the early stages really involve a lot of empathy, right? And it kind of reminds me, sometimes the patient healthcare practitioner model, it's a lot like the parent-child model, and I don't mean that in a disrespectful way to the patients, but if you look at when, if you were advising a parent on how to connect with their kids when, say, there's discipline issues or, they're not tidying up their room, I don't think there's anyone out there that has become terribly motivated by someone criticizing them or yelling at them, right? But what works is when you show compassion and you empathize. Sometimes in the healthcare model, I think that it's a bit hard for us because we think, okay, if we do too much empathizing, are we telling them that it's okay they're not exercising, right? So what I really suggest, and again, we'll kind of be looking at this in the model, the early stages, if someone really can't tap into their motivation, I think it's really worth it to kind of put aside the goals, not try and set necessarily concrete goals, but to really explore that, to validate their concerns, like if they're saying, oh, it's just a pain, and I'm older now, it's hard to find the time, to really actually engage them and ask lots of questions and to be really curious, like to say, well, what gets in your way? Like what makes it hard to find the time? And sometimes as they talk a little bit more about that, like if someone's not trying to convince them but is actually giving them airtime to talk about what gets in their way, they might start to hear why maybe it's not 100% accurate. Does that make sense, Debbie?
Yes, can you hear me?
Yeah, I can.
Oh,
sure.
okay. Yeah, usually it's not so much about a time issue, it's more about in the wintertime it's too cold, it's too icy, and in the summertime it's too hot and too humid to get out for a walk, and they usually don't drive, and because I'm in a rural area, it's hard for them to get out, so it's
yeah, their options are
without
more
me
limited.
telling them what to do, it's difficult for me to, I'm not sure how to word it so that they can come up with the goal themselves.
Yes, absolutely. And what happens when you try and give them ideas? Do you find they come up with lots of buts, like lots of reasons?
Yes.
Why they can't? So one of the issues that I do think comes up for a lot of people is the grief, right? The grief about being diagnosed with diabetes. And with a lot of those patients that you're describing, it's probably also the grief about getting older, about just adjusting to those life changes. And I wonder if you kind of help to point that out. And sometimes what I do too is I use like the patient in my back pocket technique. I remember a psychologist training me called it that years ago, and I always think about that, where maybe I'm thinking of another patient who was able to start exercising, or even someone I know, and I might say, oh, like I worked with someone who was finding it really hard for the same reasons you do, like it's hard to find the right temperature outside, but they got a couple of hand weights, to have at home, or they did, maybe they got, some kind of equipment that helped them to walk at home, and they found that that was, it was easier than to just do 10 minutes here or 10 minutes there. What are your thoughts about that? And sometimes I find that when I refer to it as another patient rather than my idea, and sometimes it comes from other patients or sometimes it's kind of a combination of different things I've seen, that sometimes that feels a little bit less instructive to them and they might open up a bit more to it.
Okay.
I don't know if you think that might be worth trying as well.
Yeah, I'll try that.
But even,
Thank you.
Describing a bit about the grief process to patients, I think, is really helpful. Actually, I write some articles for an online diabetes magazine called A Sweet Life, and there was one I did, I guess winter, going into the winter, about grief and diabetes. And you can Google it. If you Google Michelle Sorensen grief, or you go on A Sweet Life and you put in my name, you'll see the articles I've written. And sometimes part of the reason I wrote that is I wanted to have something in writing that I could give to my patients with diabetes to help them to understand, you know, kind of the grieving process, and how sometimes those different stages, like the denial or the sadness, you know, can get in the way of making the changes we need to make, right? And you know, even when I work with older patients, I find that having someone take the time to say that, to say, you know, maybe you're grieving as well, because this is a really hard change in your life, and it is a pain to have to think about the diabetes. And just taking a meeting to kind of talk more about that, it's interesting how, like, that empathy and, you know, having someone really take the time to explore that with them, maybe it'll move them a step closer to change as well.
A lot of my patients have had diabetes for decades, so it's
for many, many years. Yeah.
Yeah, something they've been dealing with for years, so it's like it's not that important to them anymore. Like
they've kind of, which is interesting because I find some of the young adults with type 1 that have had it since early childhood, I find that they're a bit in denial about their diabetes, as in they don't want to think about it. Like, they'll end up coming out and saying, when we do thought records, they're like, what it comes down to is I don't want to have diabetes. So I'm trying to pretend I don't have it, and then that's not making the situation better. So I still think even sometimes with people who have been diagnosed, I mean, it's not true for everyone, but sometimes the ones who have been diagnosed a long time, I mean, that's part of the problem, is they need to really work on accepting that it is an issue that they have to address. And as you said, like, the fact that they're coming to appointments with you, they know, at least to some degree, that they need to attend to it, right? But those are challenges. Like, I hear what you're saying, when you're in a smaller community where there's probably less, you know, recreation options in terms of indoor places, and then for older people dealing with the weather, those are significant issues. But of course, if you can tap into their motivation, I mean, even doing the stairs a few times a day, if they have stairs in their houses or something like that, could be helpful. So I do wonder about really trying to, like, you know, just spend some time showing compassion and asking them to talk about, you know, what they think might help, or, you know, if there's any kind of possibilities that they could explore. Even if you can get them talking about change, it might bring them closer.
Okay. All right, thank you. I'll try those.
Yeah, thank you, Debbie. Any other questions at this point? Or?
Well, I don't see any typed out.
Okay, we'll move on to the next slide. So here's the approach that I was referring to, and kind of, you know, a 4-step model, right? So we're looking at first establishing alliance, and that was what we were just talking about a little bit with that example, that we want to really listen with empathy. And of course, this is something that I know you all do in your practices as part of your practice. But if we think about it really being the first step, that we have to establish a bond with the client, with the patient. So we listen with empathy, we express support, and we convey respect. The patient is an expert too, right? They're an expert in their diabetes or in their situation. And then hopefully you're able to get closer to agreeing on goals. And then we want to, when we start working on, you know, really getting to the underlying issues, we want to uncover cognitions. So we try to be open and curious, withhold our judgment. It's not that we can't have judgment, because we all do automatically. Every human being does. But the trick is to be careful about checking it and recognizing it so that we can manage it. And using conversation and written word to gain insight about thoughts. So if someone's, you know, describing their thought process around why they don't check their blood sugar when they get up in the morning, or why they haven't exercised in so many months, if they say something that you think is really interesting, it's great to highlight it to them. Sometimes when people hear their thoughts reflected back, you know, if you say, wow, it sounds like you found it really hard to get back on track with your eating, but you're also expressing that you're really frustrated by that, you know, that you're not happy about it. it sounds so obvious, but still when people hear their thoughts reflected back to them, when they hear you say their thoughts out loud, it can help them to identify what's getting in their way of change. And then hopefully what happens as we uncover cognitions and we start to work on them and start to challenge some of them and balance them out is that we regulate mood. So we portray, when we can, we try to portray moods as existing on a continuum. And what I mean by that is that, some patients can really label themselves, like they say, well, I haven't exercised because I've been depressed. It's okay to say that, but I often do point out to patients that, we all have times we feel depressed, and it's to look at the intensity of it, where sort of on the continuum are they, and how do we bring it back to a manageable level. We avoid labeling when possible. For example, and this is probably not, always an issue for all of you, but I know that in my field it's very easy for people to become identified as if they're anxious, having an anxiety disorder, or if they're feeling depressed, just having depression. And then patients think about these as being sort of fixed labels that will always apply to them. And I just always caution that if we can, we talk about feeling down or feeling anxious, and that's something that sounds more changeable than having a disorder or just being depressed, period. And then we try to normalize and set realistic expectations in terms of, how much we're looking to change the mood. So it is okay to have times where you feel anxious. I often say to people, and we wake up in the morning because the alarm goes off. If we're a little anxious, it's good because it means we get out of bed in the morning. We don't want to eradicate anxiety, but we want to bring it down to a manageable level. Type 1s who are anxious about low blood sugars, that's actually protective. We just want to have the anxiety at a manageable level. Thinking about future complications to some extent also can be motivating, and it's okay to be a bit anxious about protecting your eyesight. But when the anxiety climbs too high, it's not productive anymore. And so then when we look at the final stage, we're looking at activating and changing behavior. So here we're trying to be really collaborative, really looking at what the patient's ideas are, breaking down goals into specific steps, and also being able to prioritize goals. And this is like a really brief outline, but I tried to go, for those of you who are interested in reading a bit more about the goal setting, in the handout, I tried to go into a bit more detail and just gave sort of some of the basics of goal setting and some example, sort of quite helpful questions to help with goal setting. So now we're going to look at this sort of model in a little bit more detail, and we'll try to go through it quickly enough that then we have time. There's another case example at the end that I'd like to talk about. But the first step here, establishing alliance. So if we have an overview of that, empathy really means putting yourself in the other person's shoes. So trying to really think about how she or he is feeling. So when you have someone who comes in and they're having trouble kind of putting into words, you can really try and put yourself in their shoes, and then sometimes you can reflect on how it seems they're feeling and get more information. If we make empathic statements like, if I said to Amy, oh, it seems like you're feeling pretty down about the trouble you've had managing your sugars lately, and if she said, well, no, actually I haven't really been down, but my endocrinologist was concerned and I think it's a good idea to work on it, that's okay if I got it wrong, because now she's giving me more information and I'm understanding better the way she's really feeling. So express your desire to help. I know this seems pretty obvious that we should all do this, but I know myself as a healthcare practitioner that sometimes I forget to say it. When I meet a new patient and they're leaving, I might not think to say, oh, I'm so glad you came in and I'm really looking forward to working with you. But I know that when I do, I can see the response, and it's really, or some of them will say, oh, I'm so relieved to hear you say that because I wasn't sure if, you thought I could get better. So expressing your desire to help and the fact that you're glad that they came to meet with you really does help patients to feel more connected. We also want to try and be, really clear in our own minds, and therefore bringing it into our interaction with patients that we're both experts, right? That we have expertise in helping people, whether that's facilitating change or, for many of you, it's about educating. You have lots of information about, whether it's insulin or managing blood sugars. But without the information from the patient about their life experience and how they manage their diabetes, we can only get so far. And then we want to acknowledge and commend patients' efforts. I referred to this earlier, that looking at the efforts is so important, not just the outcome, and that sometimes we take note of it internally, but we need to say it out loud because patients really, it helps them a lot to hear that we're recognizing it. And then discussing the patient's goals, hopes, and concerns. So really coming back to checking in, saying, is this what you want to be working on? What would you like to put on the agenda? So a little bit more about establishing the alliance in terms of asking and listening. And again, this is all in some ways so obvious, but always good to review, and I always find it helpful when I talk about it because then I remember how to use these things in my practice more. But good listening really involves trying out different questions, right? So it involves using open-ended and specific questions. For example, do you have any positive changes to report about your diabetes care the last few months? Sometimes people forget that they can tell us about the good stuff too and not just the problems that need to be solved. How are you feeling about your diabetes management? Sometimes when we say to people, how are you? They just, sort of say fine or not good. But if we say, how are you feeling about your diabetes management these days? Who knows what that might mean to them and what it might bring out. What kind of information or help do you need from me? Again, a very collaborative approach where instead of us saying, okay, we need to cover this today, we're looking to them. And keep in mind that I know this, certainly in some education settings, like I know there's information that some of you do have to cover, and that's part of agenda setting too, that you can say, okay, I need to make sure I cover this and this today, but what are you looking for? Let's make sure we put that on the agenda too. A good question for people who are struggling with change, and maybe this goes back to, the example of elderly clients who come in for appointments, so they're willing to talk about things, but having a hard time coming up with ideas or willingness to change, for example, with exercise. If you say, well, if things were just a little bit better in a few months, just if you had made a few little changes, what would need to be different in your life? Like, what would that look like? And maybe then they can just think about those first steps. And a question I do like to ask sometimes would be, what would be a sign that you're making progress? Like, again, it's just rephrasing it. If things were better, what would be a sign that things were getting better? And the reason I think these kinds of questions are so important is because we just don't know. We might expect one answer, and then we might find out something totally new about how the patient is thinking. So if we're genuinely curious and open-minded, it's always really interesting what comes out. We never know what the patient will tell us. So I'll just pause here to ask if there's any questions or comments. Danielle, anyone coming up with anything?
I don't see any at the moment.
Okay. Well, everyone is welcome if there's any thoughts that they'd like to share. So I'll move on. Yeah.
I'm sorry, and I just want to say, at the end when we have the open question-answer period as well, I'll unmute everybody in case people are having problems with the chat function or the raise the hand function.
Excellent. Thank you, Danielle. So now we'll look a little bit at uncovering cognitions. Most patients with diabetes do need to gain insight about their negative thoughts before they can change behavior. And there's different ways to identify the cognition. So, when I was describing the case with Amy, a lot of that was just conversational. So with her, it was pretty easy. She was chatty, and she had some good insights, and she was able to identify the thoughts getting in her way. Sometimes we have to use more concrete techniques, or at least it's worth a try. So one that I'm going to talk about in another slide is the downward arrow technique. And another good technique is the thought records. And I will mention in my last slide, there's a list of resources that are helpful. And when I was first learning about cognitive behavioral therapy when I came out of grad school, the first book I read, which is still one of the best books in our field in CBT, is Mind Over Mood by Christine Podesky. And the thought records I use are from that book. And what I really like about her thought records is that she's the one who incorporated the evidence piece. So instead of just having people say, okay, here's my irrational thought, here's a rational thought, we look at what are the negative thoughts and what's the evidence that challenges them and the evidence that supports them, and how do we come up with more balanced thoughts. So that's a book I really recommend for anyone interested in learning more about CBT. And it's a book for patients as well, for clients, but it's a great book for practitioners. So the reason that we use all these techniques to pull out thoughts is that it's much harder to challenge thoughts that are trapped in our head than those we say out loud or write down in black and white. So here's a little bit about the downward arrow technique. You want to be curious and help patients to peel back the layers of their cognitions. So if you picture, writing a thought on a paper and then literally you draw an arrow down and you write their next thought, that's what the downward arrow technique is. And it's us just asking little questions in between, like, well, what does that mean? Okay, well, what does that mean? So I'll just give an example. If I say to someone, if I reflect back to someone and I say, okay, you've been feeling guilty because your sugars have been really high. Like, what does that mean to you when your sugars are high? I'm not managing my diabetes. I'm being lazy. I'm just being lazy. And so, often a conversation would stop there because the patients told us what they thought, or we might try and convince them that they're not lazy. But instead, if we go on and we say, okay, well, let's not be afraid of that thought. Let's look at it. What does that mean if you're being lazy? Like, what does that say about your life or your future? Well, I'll end up with other health problems. And then what then? What will that mean if you develop other health problems? It will prove what a failure I am. I'll end up proving what a failure I am. It will be all my own fault. So although these thoughts don't sound very happy, people saying it out loud is really important because, first of all, you can reflect back at the end on, what you perceive from those thoughts. Like if I had that conversation, I would reflect back, wow, it does seem like you're really hard on yourself and there's a lot of pressure you're putting on yourself. But even people saying it out loud, it can be a real relief for them to let out what lies beneath these behaviors and these emotions that they're experiencing. So the way I think of it is that we have to keep peeling back the layers. When patients voice what's being trapped in their head, they move closer to change. So now we look at how other ways to change thoughts. This is kind of touching more on the thought record technique, which, as I said, is in Mind Over Mood. Insight is really the first step to change. So we want to ask patients to identify their emotions in an upsetting situation. So on a thought record, and as I said, I do have a completed one from a patient I was working with. It's based on a patient I was working with about their diabetes. So we first identify the situation, then we ask the patients to identify their emotions in an upsetting situation, and then we ask what thoughts go through their mind. So in the end, we highlight the central hot thought, and we say, well, what's the evidence that supports it, but also what's the evidence that challenges that thought? So in doing so, we help patients to develop new, more balanced thoughts. So you can see it's just a more concrete, detailed version of what hopefully we do in our conversations when we have meetings with patients, helping them to identify the problematic thoughts, to challenge them a bit, to say, well, is that really true, and to move forward from there. So definitely, if you want to learn more about this, Mind Over Mood is the book that I would recommend. And you're also welcome. My email is on the first slide, and if anyone wants to contact me, after today with questions or thoughts, I'm very, very open to that. So now in terms of regulating mood, once we normalize moods, part of being human is to experience a broad range of emotion. Having diabetes means that you're going to have some stress, some distress related to the diabetes. And helping them to voice their thoughts, hopefully the moods start to regulate. A really important thing, as I mentioned earlier, is sometimes discussing moods as being on a continuum. And we want to set expectations that we're not trying to completely get rid of negative moods, but bring them to a manageable level. And behavioral activation is obviously always our end goal. This is kind of like the hot topic in diabetes management, right? How do we actually help patients make behavior change, modify behaviors? Once the patient is able to identify some motivation, then you can get some goals established for behavior change. Mind Over Mood also has some really good advice on how to use activity scheduling. You find a lot of this in the chapters on depression and anxiety, but basically one approach that I really like is where you use activity scheduling, and you could have people do this just using their own calendar, where you ask them to track their activities and look at their corresponding moods for a week. So someone who's really been down and is not attending to their diabetes, if they were to look day to day at how they're feeling at different times of the day, and they notice that certain behaviors and certain activities help their mood, then it can be a really good motivation to get more active and to do more, not just to do more physically, but to be more productive in their life. So research has shown that activities that are pleasurable or that lead to some kind of accomplishment really help lift mood, and of course when mood is regulated, people engage in more healthy behaviors. So you can always do an experiment like this where you get people to track their moods and then explore the results and say, well, when did you feel better? Did you notice any patterns? What did you learn from doing this for a week? And now to talk a little bit more about goal setting. This is a big part of behavioral activation. So once people are ready to set goals, I really recommend developing a step-by-step plan. So for each goal, for example, exercising more, you want to break it down into the smallest steps possible and then set really realistic goals about how to tackle that. Often I'm encouraging people actually to scale back on their goals, because sometimes when people are in a meeting with the healthcare and wanting to be, the ones who want to be model patients, they, in the moment, think, oh yeah, I'll do this and this, and I'll exercise 5 times this week. And I always say, you know what, let's set you up for success. Let's start small, and if you exceed it, then you've exceeded your goal. If you do more, that's great. So we want to look at which goals will yield the greatest benefit. Also, of course, which goals do the patients feel most ready to work on first, and those are the ones we choose. And then you can monitor their progress by tracking their emotional changes along the way as they complete tasks. So some of the questions we can ask around goal setting are, which goal is most important to you? What would be the easiest to accomplish? And what small steps would show progress towards this goal? Now I'm just looking at the time, and I'm wondering, Danielle, whether we probably have time to do the case study, but if there's questions and discussion, I don't want to run out of time for that. Maybe we could just check in and see if people have questions right now.
Sure. There's none listed at the moment, but let me just unmute everybody in case somebody wants to speak up. So that'll just take a quick moment.
Okay. If not, then I'll go through the case study. But
okay, so everybody should be unmuted. So if anyone's got a question or a comment, muted. So if anyone's got a question or a comment.
No? Okay, well, if everyone's okay, then I'll go on with the case study. I just didn't want to use our last 5 minutes if people had questions at this point.
Okay, in that case, I'm going to mute everybody again, but if somebody has a comment or a question, feel free to lift up the virtual hand or to put something in the chat.
Perfect. Thank you, Danielle. So the case study I chose is a patient who had type 2 diabetes, which generally there's a lot more patients with type 2 than type 1 out there, so I'm hoping that this will resonate with some of you. So Mary is a 55-year-old patient with type 2 diabetes. And when she came into therapy, she admitted that her diabetes management had not been very consistent since being diagnosed about a decade before. Some of the thoughts that she sort of described was that she was judged by her family, people weren't happy, her diabetes team was disappointed in her. She did identify right away that emotional eating was a long-standing problem. And she had recently seen a new endocrinologist who was very empathic, and Mary, who tended to be quite guarded with healthcare practitioners, had opened up to her a little bit and then accepted the referral for counseling because I think she had some trust in this endocrinologist. So if we look a little bit at some of the components we've discussed today, we'll try and apply them to Mary's case. So first of all, for alliance, with a patient who's guarded like that, obviously you kind of move slowly. And I think that for Mary, just a big part of telling her whole story, you know, I invited her to talk about it from the very beginning, it was helpful for her just to talk about it and to say it all out loud. And she felt heard and understood, and I accomplished this with, you know, empathic listening and making reflections on what she shared and showing warmth and caring. As Mary shared her worries and frustrations regarding diabetes management, I did try to highlight the efforts she'd already made because, you know, like many patients who were sort of self-critical and insecure about their management, she tended to diminish the efforts she had made. You know, she didn't give herself credit for that. So I didn't draw attention to them because that was enough. Like, she did need to make changes in order to improve her diabetes management, but I wanted her to see that she was able to make change because she had done some really good things over the years. So yes, she was so focused on her failure to achieve her target A1C. She was very focused on the A1C and can believe that hers must be so terrible compared to everyone else. So she never gave herself credit for what she had done, which was that she had added exercise to her schedule. She had been a little bit more active, and she did try to test her blood sugar twice a day. She didn't always do it, but generally she tried to. And obviously, you know, as I'm sure many of you are thinking, for a lot of patients with diabetes, that's a lot, right? We have patients that go weeks or months without checking their blood sugar. So Mary started to challenge her negative thoughts. So now when we look at the balancing thoughts and moods piece, she did start to challenge her negative thoughts about diabetes management by gathering some evidence in session and then trying to continue recording it outside of session. So we would choose particular negative thoughts she had, and I would say, well, we would write down a few items that challenged it, like her thought that she was a failure. And then she would go away and try and add to the list, you know, look for evidence that said she was not 100% a failure all the time. So again, getting away from the black and white thinking and thinking more on a continuum. And I will just mention at this point that in the handout, we won't have time to go through it all, but there is a checklist of cognitive distortions at the back of the handout. And I developed this at one point for a presentation I was doing, and I just thought it might be helpful for some of you because it goes through, it's from the Feeling Good handbook, which is also listed on your resource list, but it goes through a checklist of cognitive distortions. So these are cognitive distortions that are identified by the author of that book, but then I wrote my own examples, many of which are from people I've worked with, patients I've worked with. So cognitive distortions like all or none thinking or mental filter, discounting the positives. So you might find that list kind of just helpful to read through and helps you to think about some of the problematic thinking that some of your patients might have. So gradually, by exploring thoughts and kind of challenging some of them, Mary began to see herself as someone making an effort but dealing with a difficult disease versus being a failure, period. And then change seemed more possible to Mary. So one of the things about anxiety is that it leads to avoidance, and she was able to see that she had avoided some of her most difficult changes because they made her anxious. Not because she was lazy or because she was a failure, but because, like many people, when she gets anxious, she avoids things. So as she balanced out her negative thoughts about herself and started to see herself a little bit differently, her anxiety was lower and she had a little more confidence to start to tackle her emotional eating and challenge herself on that. So in terms of goal setting and behavior change, as I said before, I really am a big proponent of setting attainable goals and realistic timelines for behavior change. So with Mary, she's another one where I would ask her to scale back sometimes on her next steps. Not that I would discourage her, but I would say, okay, the first week, why don't you aim for a bit smaller and then add that to, you know, the second week or the third week. She gave herself credit for even small changes, you know, like she'd start one week just improving her breakfast. And she really, by hearing me say it, she started to really believe that rather than beating herself up all the time for what she wasn't doing, that if she gave herself credit for what she was doing and she even let herself feel, good about it, that actually would inspire more change. She started asking for support from friends and family. Like many women, she had lots of people around her who she would say were supportive, but wasn't necessarily good at using those supports. So she started asserting herself and asking a friend to go for walks, asking her husband to help out with dinner so they were more likely to eat a healthy dinner. And she also was willing to add some relaxation exercises to her schedule, like remembering to do some deep breathing and that kind of thing. And this was over probably only about 5 meetings, so that those might have took a while, maybe even up to 6 months. Not everyone comes in frequently, but because we worked at it gradually, she was able to start incorporating these changes in her life, and it didn't feel overwhelming. So in summary, if we look at what we've kind of talked about today in the presentation, I think the first thing is that we always want to focus on our alliance, our relationship with the patient first. And one of the big teachings of motivational interviewing, which maybe we'll talk about another time, is that we have, as health professionals, we tend to have this righting reflex. Like we see a patient and we see problems to fix, and sometimes, I know I have to really check myself, like the impulse is to kind of dive in and suggest changes. But you really want to make sure that, first of all, the person feels a certain comfort level and connection with you. And that doesn't necessarily have to take hours. That might just take one initial meeting to achieve. We want to be collaborative. The patient is an expert in his or her diabetes, and you're an expert at facilitating change. That's the way we want to try and think about it. Once thoughts are balanced and moods are more stable, behavior change is possible. Remind yourself of that. Sometimes, we feel discouraged with patients, and it just seems like they're never going to change, and it's true that we can't help everyone. But I've seen some people that, do not seem anywhere close to change. But when they start to balance out their thoughts, they don't have to be 100% better, but when they're a little more balanced and their moods are more stable, behavior change does start to happen. And I guess the last thought I would put out there is that if motivation is not apparent, if it seems like this person is not ready to make change, then we might as well spend the time trying to build a relationship and connect with them, even if they want to spend a little bit of time talking about things that are not diabetes related, because setting goals with someone who can't identify any motivation is probably wasted time, but building a relationship might actually be the next step to them being willing to engage in some discussion about change and be open to your advice. When patients feel connected to their healthcare practitioners, they're much more likely to follow our advice. And then just the last slide is a couple of books, diabetes related, and a few online resources at the end that some of you might be interested in looking at. And if anyone has any questions about them, you can ask me now, or if you think about anything later or something that you don't feel comfortable asking right now, you're certainly welcome to email me. sorensencbt@gmail.com is my email, and it's on the first slide. And I'll hand it over to you, Danielle.
Well, that's fine. So unless anybody else has got any other questions or comments to make, I'll unmute everybody who's still left online one last time. Otherwise, we'll just say goodbye and thank you for coming. So any last questions or comments? So it doesn't seem like it. So again, thank you everybody for attending, and thank you, Michelle, for doing such a wonderful presentation.
Thank you.
Thanks very much, Michelle.
See everyone at the next webinar.
Okay, thank you, everyone.